Hi, I'm David Liew for Room Now from ACR 21, and it's a real pleasure to have the GCA PMR panel back again. Always have great conversations with these three colleagues of mine, and it's really delightful to be able to sit down at the end of ACR 21 at the end of a long meeting and have a chat about all that's great and good in GCA and PMR. So by way of introduction, I think these three need no introduction, but Len Calabrese from the Cleveland Clinic, Sarah Mackie from Leeds in the UK, and Richard Conway, of course, a Room Now faculty and from Dublin in Ireland. Welcome to all three of you.
David.
Great. And so today, I think we've talked a little bit about everything that's been going on in GCA and PMR, and it's really amazing the therapeutic advances that we are seeing at the moment. You know, a few years ago, we were just talking about looking at observational studies with clinics trying out methotrexate and leflunomide and seeing tocilizumab on the horizon, and now we've got a whole plethora of choices. So maybe, actually, Len, I think you were keen to talk about the baricitinib GCA trial. That's abstract 1396.
Yeah. So, I mean, this is a open label study. So, you know, your knee-jerk response is not to get too revved up over this kind of stuff, but it's novel, and you know, this is done at the Mayo Clinic, and you know, Ken Warrington and Connie Wayand, and these guys know what they're doing, and so it has gravitas to me to begin with. This was presented very nice by a young guy, Matthew Coster, who was a fellow, made a very nice presentation. So basically, they took GCA patients who had all relapsed within a 6-week period of time. And this cohort of 14 patients. So these are people that are treated with a standard of care, these are problematic patients, and they are likely to relapse again. So they're randomized they're not randomized. They're all placed on a regimen of baricitinib at a standard dose, 4 milligrams a day. And then over a period of time ranging from 15 to 22 weeks, they got rid of the prednisone. So totally got rid of the prednisone. And if you're on 30, it took 22 weeks. If you're on 10, 15, and 20, somewhere in between. And then the real acid test here was that between the end of the prednisone and 1 year, and that's up to 30 plus weeks, they remained on baricitinib. So what happened to these people? So the bottom line is that there was only a single flare. So this is prednisone-free remission from 15 weeks out, not just in anybody with GCA, like, we're thinking of tocilizumab trial. These are all demonstrated that they were relapsers. And, the data are the data. And so, the big issue here is this is an older population, and scary JAK inhibitors now with all these warnings floating around the world in an older group, but it was very well tolerated. There was really no significant toxicity noted in this. The acute phase reactants controlled, and it was steroid free for a long time. So, my take is that this merits, a more thorough and randomized approach to this, but I was impressed. You can treat from that get-go.
Yeah, were you surprised by it all? I mean, I know that we've been waiting for these data to come for a bit, but Barry and relapsing GCA have such good numbers and no ischemic symptoms. Was that a little bit unexpected for you, or do you think
I was impressed. This type of JAK inhibitor, all JAK inhibitors that we have at the present time, if you think about what's going on, you gamma interferon, IL-21, GM-CSF, they're all nailed by this, So IL-6, why not? This is begging to be done. These are all the leading candidates for therapy. So let's just, use the Malleus maleficarum on them and smack them down.
Yeah, I mean, well, Richard or Sarah, do either of you have any thoughts? I mean, Richard, you've obviously, I think in some ways, ustekinumab hit some of those same immunological highlights, and that was you kind of leading that study back in the day. Did this kind of resonate to you, baricitinib and GCA?
Yeah, it reminds me quite a bit of our study, like slightly different population and design, but yeah, very positive results in an open label fashion. I really hope they don't run into the same next problem that we did and not be able to get anything more further off the ground, and that the general fear over JAK inhibitors in these vulnerable populations does not put a stop on things. But I think, JAK inhibitors in many ways make the most sense of anything to target, because you're targeting multiple different cytokines in the GCA pathogenic process.
Yeah, absolutely. Well, why don't you tell us a little bit about, because I mean, I think you were particularly interested in the late-breaking Titan study looking at secukinumab that was late-breaking abstract number 19 and the late-breaking oral abstracts, looking at that phase 2 secukinumab study, which was also, I think a lot of people were saying was pretty impressive as well.
Yeah, no, I think it's great. We've got multiple different agents being investigated for GCA, which I think we really need. There's this kind of general attitude when tocilizumab came that, this was the end of it, and we had an agent that worked. We didn't really need anything else, but that's manifestly untrue. It doesn't work for everyone. People who can't go on it. We've had all these problems with shortages as well. We weren't able to give people tocilizumab for quite a while there because we couldn't get any. So it's great that we're looking at new agents. Secukinumab, targeting interleukin-17. So again, going back to our own study, the Th17 cells making interleukin-17 are an important part of GCA pathogenesis, so it makes sense that it would potentially work. This is a double-blind, randomized control trial, phase 2, so relatively small, 52 patients in it, but very, very positive outcome. So at week 28, I think it was 80% in sustained remission with secukinumab compared to 20% with placebo, with glucocorticoids alone. And at week 52, I think it was 59% versus 8%. So they're really good numbers. They're not quite as good as the phase 2 tocilizumab trial, but they're almost there. So to me, it's looking like maybe this could be almost on a par with tocilizumab. We absolutely need to wait for that phase 3 study, which will be done, and see if that's as positive. No unexpected safety signals in this either, which is encouraging.
Yeah, Sarah, did that surprise you? I mean, that's in many ways. I think that a lot of people had been slightly surprised by the starting to utilize secukinumab in this context, but it probably isn't that much of a surprise for those who have thought a little bit about GCA.
Well, I guess it's, that what I'm surprised about is that for so long, we've all assumed that steroids is the only thing that works for giant cell arteritis, and it's this magic disease that responds to no other medications. DMARDs, biologic DMARDs, conventional synthetic DMARDs. Why do they work? Why should we try them in giant cell arteritis? We should just give them steroids. And I think it comes from the exquisite response to prednisolone at the start of disease. So we're all fooled into thinking that sorts out the disease, and that makes everyone better, that we don't need anything else. But I think GIACTA shows us that actually biologics do have a role. And so now, lo and behold, all these additional medications that we all assumed were only for other autoimmune diseases and not for giant cell arteritis, funnily enough, we're starting to see signals across multiple different sort of pro-inflammatory pathways. So maybe we should question how we've been looking at GCA all these decades and start to see it a bit differently. It's a proper autoimmune disease, and if you give sort of biologic therapies, it's not just IL-6, but it may well be other pathways as well that may help. Now, of course, there's caveats here. This is a phase 2 study. It's fairly small. There were a fair number of dropouts, which gives issues for potential bias occurring post-randomization. The analysis used Bayesian analysis, but including non-responder analysis, which I do not fully understand, and is not detailed extensively in the abstract, because of course it's a meeting abstract. But if you look at the trial protocol is described, is now published, and it doesn't describe the Bayesian analysis in great detail in that either. But it does say that they used a non-informative prior for the intervention arm, but an informative prior for the non-intervention arm. So I'm not a Bayesian statistician, but it seems that they're not treating the intervention and the placebo arm equally in their analysis. So I just would like to know what's going on there. And the other funny thing, if you read the protocol, they were originally planned it to be a 28-week treatment. And then when they started recruiting, somebody decided to switch it and to make it 52-week study, and to keep treating with the investigation agent for a full year. So because of that, so they kept the same primary outcome, but they added a new secondary outcome. And there were some things that they might have done a little bit differently if right from the start they decided to do it with a year. But they recruited ahead of time. They were fully recruited up by April 2020, having only started in 30th of January 2019. So they did really, really well. Collection academic centers in Germany. And, it's just very encouraging results. But I think we do have to wait for the phase 3 now to really confirm those findings, because it is small numbers and you can just get these things just from quirks of chance.
Absolutely. It's always the kind of thing where we want, you've put the value that you can get from looking through the archive log of clinicaltrials.gov to see the changes and and how it's evolved. I'm sure it'll wash out in the paper. But speaking of proven therapeutics, though, obviously tocilizumab is now our non-steroid workhorse for GCA, but it's hard to escape the steroid context, isn't it, Sarah? You are definitely an expert on this. Yeah. So
I think since the Gusto trial, there have been questions about how quickly can we stop the steroids. So with Gusto, they had IV methylpred and then steroid free after that with tocilizumab, and it didn't get through its 2-stage design, so it wasn't as good as they hoped it would be. So this is an interesting study. So this is the abstract number 1413, which is an investigator-initiated trial, open label study, single arm, and led by Sebastian Unizoni and colleagues at Massachusetts General. And they recruited 30 people with relapsing giant cell arteritis. 30 with giant cell arteritis, 13 were relapsing, and the remainder were new onset. And they treated them all with 1 year of tocilizumab and a taper of between 20 and 40 prednisolone, going down to 0 in 8 weeks, which is shorter than Giacta and many of the other biologic trials that we've seen over the past few years. And actually, only 7 out of 27 relapsed during the 52-week period, and the mean time to relapse was 15 weeks, which is not bad. So yes, some patients relapse, but it's fewer than perhaps we'd worried about. And so this is starting to define how quickly can we withdraw prednisolone in patients who we're treating with tocilizumab alongside. I guess one caveat for this is that they excluded patients who had previously been treated with investigational agents for giant cell arteritis, but tocilizumab is not investigational. So the patients could have had tocilizumab previously, as long as it had worked and they hadn't had to have it stopped due to lack of efficacy. So I guess it's what would be really nice to see when the full report comes out in a publication is to know a little bit more about the patients that went into this study. How many of them had previously had tocilizumab? Was there a gap between their previous tocilizumab and entering the study? And actually they had CRP and ESR. The mean CRP ESR at baseline was fairly high, so they can't all have been treated by tocilizumab at baseline. So it'd be really nice to know a little bit more about the characteristics of those patients to really help understand the context of this. But it is really encouraging for withdrawing prednisolone quite quickly in patients where we are concerned about adverse effects of prednisolone in patients either with new onset or relapsing giant cell arteritis. And again, very small study, open label, but for clinical practice, it is encouraging.
I mean, Len, I remember this time last year when we were sitting around with the four of us talking a bit about Gusto, and I think I remember you saying that you would have been reluctant to recruit anyone into Gusto. I think that's proven very fair and true. I think with the course of time, how were you surprised that 8 weeks was enough? I mean, compared to the 26 weeks of GACTA?
I mean, it's kind of half full, half empty. I mean, it's not like people that aren't flaring there. So, if you look through all these studies, that I mean, there's a population of people that, that either need glucocorticoids or need something that will really spare glucocorticoids. This is kind of half and half to me.
Mm-hmm. Absolutely. Richard, I mean, did you have any thoughts on kind of where the optimal steroid dose sits? I mean, 8 weeks does seem short, and it doesn't necessarily seem like we've hit all the right buttons on this.
It does seem short, but I suppose it brings home the point that we don't really know what we're doing with steroids in this condition. We don't know how much to give, how long we need to give it for. We've tended to go high for a long time because we're scared of the disease, and we're not scared enough of the steroids. So I think it's great that we're looking at these things about treatment duration and intensity, and hopefully a bit more time, a bit more study, we can find the sweet spot with steroids.
I mean, it's going to be interesting to know whether, patients on biologics at 1 year and no glucocorticoids still have inflammation in their temporal arteries like steroid patients do. And, I mean, we don't have any clue about that.
Yeah, and I mean, I think we've obviously seen some data about PET-CT studies, but it's hard to know how that actually reflects to real, genuine histopathology, doesn't it? Yeah. Okay. All right. Well, the one I wanted to throw in at the end, because the spare abstract at the end, because Len said we had to do this, and I completely agree with him. Speaking of steroids and speaking about long steroid exposures, so PMR is still an unsolved disease as far as steroid sparing is concerned. There's a little bit of promise, and we saw the PMR SPARE study, which was abstract 0507, which was a double-blinded RCT looking at new polymyalgia rheumatica patients, 36 of them, and importantly, with an 11-week taper, which I think we speak a lot at Room Now about how long PMR patients end up on steroid, and we promise them that it'll be over in a year, and it always takes longer than that, and often it's very hard to get them off it at all. But in this subcut tocilizumab, looking at that for 16 weeks versus placebo, and we saw this real steroid-sparing effect and big benefits. Did that surprise anyone? I mean, I guess in some ways it was a logical target, but did that excite anyone?
It just made me wonder whether we've just been over-treating PMR as well all these years. Because if you look at the epidemiological data, there's a substantial number of patients that come off prednisolone in about 3 to 4 months without any problem, without any flare. And we've always said, oh, well, maybe they don't really have PMR. Maybe the GPs are just diagnosing them wrong. But actually, maybe they just do have PMR. Maybe there are some patients with PMR, like in the placebo arm in this study, you can stop prednisolone quite fast and they don't flare. So perhaps a bit, as with GCA, we've been treating PMR with prednisolone for 2 big doses for too long in a subset. But then there'll also be a subset who does tend to flare and is very, very hard to get off steroids. So I think there's much, much more diversity within this disease than we previously realised. And it makes it difficult to power clinical trials because I think fewer relapsed than I would have expected just from, how we generally tend to think about PMR.
I mean, Richard, Len, does this kind of ring true with your experience with PMR?
That's pretty short.
It's hard to argue with that. 11 weeks is a lot shorter than, say, a BSR protocol.
Yeah. I mean, it'd be nice to see. I'm sure they're trying to do some, mechanical learning to figure out who these people are and what differentiates them. And, and it's also not that long a follow-up. I mean, I wonder what will happen, a year down the road or something like that. But it's very, I think these are things that need to be done. It's very cool.
Absolutely. Well, I mean, there's an awful lot of promise that we've talked about today, and I think hopefully we'll see some of that step into reality. Very cool indeed. Well, thank you all three of you for joining us today for the PMR GCA panel. Go down to rheumnow.com for plenty more coverage on PMR, GCA, and the rest of the conference.
See ya.